Hello, and thank you for joining this OncLive TV peer exchange treating adenocarcinoma of the lung. Much progress has been made over the last decade in defining molecular subgroups of patients with adenocarcinoma of the lung. Many more studies are currently underway to further our understanding of how to use targeted therapies to personalize our treatment approach in these patients. In addition to targeted therapies, we also have several monoclonal antibodies at our disposal, including the recent addition of immune checkpoint inhibitors. In this OncLive peer exchange, my colleagues and I will discuss how and when to use the therapies we have available and what to consider when choosing a treatment strategy for an individual patient. My name is Dr. Mark Socinski, and I'm Professor of Medicine and Thoracic Surgery and Director of the Lung Cancer Section at the University of Pittsburgh. Participating today on our distinguished panel are Dr. Benjamin Levy, an Assistant Professor of Medicine at the Icahn School of Medicine, Medical Director of the Thoracic Oncology Program at Mount Sinai Health Systems, Dr. John Longshore, Director of Molecular Pathology for the Carolinas Pathology Group, Dr. Greg Riely, an Associate Physician at Memorial Sloan Kettering Cancer Center and Associate Professor at Weill Cornell Medical College in New York, Dr. Thomas Stinchcomb, Associate Professor for the Thoracic Oncology Program at the UNC Lineberger Comprehensive Cancer Center at University of North Carolina, Chapel Hill, and his colleague, Dr. Jared Weiss, an Assistant Professor of Medicine for the Division of Hematology Oncology at UNC Chapel Hill Lineberger Comprehensive Cancer Center. Thank you again for joining us, so let's begin. So I'm going to start with Ben. One of the title of our discussion today is adenocarcinoma of the lung, and we know that there are different subsets of non-small cell, adenocarcinoma being the most dominant one, squamous number 2. But the adenocarcinoma population is somewhat different. Can you just kind of give us an overview of that population from your perspective?
Sure. I think that lung adenocarcinoma patients, there are some important clinical characteristics to point out. Like squamous cell, unfortunately, 60% of patients do present with advanced stage disease, and I think that's speaking volumes to the need to define or declare these patients earlier through CT screening methods. Importantly, 20% of lung adenocarcinoma patients are never smokers, which is a little different than the squamous cell population. And then if you look at patients who are either never or former smokers, that percentage goes up to 60%. So this is not necessarily a currently smoking disease. Most of our patients, in fact, are either former smokers or never smokers. And then I think finally, and most importantly, we have a firmer understanding of the genetic landscape of lung adenocarcinoma. I think we are now being able to molecularly characterize this disease better, and the list of driver mutations that we have that may predict sensitivity to targeted therapies is growing. So I think it's a very exciting time for us to be treating this patient population.
Yeah, and that really was kind of a paradigm that started almost 10 years ago with the initial description of EGFR mutations. I'm going to ask Dr. Riely to kind of walk us through this population. What should we be thinking of? What should we be testing for? How should physicians be thinking about tissue acquisition strategies to make sure we have enough tissue? And then we'll also ask John after that to kind of make some comments on making sure we have a good histologic diagnosis and the issues of tissue stewardship. So what should we test for?
Well, so I think, first of all, we need to think about when we're diagnosing lung cancer, you need an accurate diagnosis. And in 2016, an accurate diagnosis means you understand the histology well and you have molecular testing done for that tumor. And because all these things drive what patients are going to get in terms of treatment, so we need to know this up front. So when we're going to get tissue for that patient, I think we've known for 10 plus years that going for a fine needle aspirate, simple one-pass needle biopsy is not enough in 2016. We're not going to get what we need in order to really answer all the questions that we need. So we need a big biopsy, whether that's multiple passes with a fine needle, multiple passes with a core needle, or even surgical biopsies. Those are the ways that we go. So when we go to test, I think I think of it in after we've passed through the histology and then we're testing for molecular testing. I've decided there's 2 levels. There's one that absolutely everybody needs to do every day, and then there's the kind of thing that many of us do to learn more, to qualify patients for trials. And the absolute bare minimum for patients is we need to know EGFR mutation status and we need to know ALK status. I think I might extend level 1 to include ROS1 rearrangements as well, because there's an FDA-approved drug with clear activity in that area. So ALK, ROS, and EGFR are really critical for all of our patients with lung adenocarcinoma. And I'll extend the lung adenocarcinoma group to patients who have small biopsies for squamous cell as well. We don't always know that that's a pure squamous tumor from a small biopsy, and I think we need to include those patients in a lot of our molecular testing. So when I go past the first level that everybody should be doing, then I think I get into things that are a bit broader and can take more time. So I'll say the first level should be done in clinic in 7 to 10 days. We should have those results to treat patients.
And can I just make the point that those three things we now have, at least in the first two, EGFR and ALK, we'll get to this later, we have FDA-approved therapies that are better than chemo.
Absolutely.
That's the reason to.
That's right. Randomized clinical trial data said platinum-based chemotherapy is inferior to targeted therapy for those patients. So we need to know that up front. So when we get to the second level of molecular testing, there's a broad spectrum of things, and a lot of people take different approaches to finding these, but there are things like BRAF mutations, MET exon 14 skipping mutations, a whole range of things that we're really just beginning to understand, and I think are really going to be important over the next few years, but today I can't expect everybody to have a platform for that.